I'd like to continue on to our third session of the day, which is preparing for the new normal. So as we continue to progress towards the reactivation of our healthcare system and the reopening of society, how do we prepare our patients, hospital system, and community for this new normal? Our speakers for this sessions are Dr. Milana Boukhman Trounce, who's a clinical professor of emergency medicine and director of biosecurity in the Department of Emergency Medicine at Stanford. She's also the chair of biosecurity for the American College of Emergency Physicians. Next, we'll have Dr. Gila Hyams, who is the Director of Nursing and Director of the Teaching Center for Trauma Systems, Emergency and MCS at Rambam Healthcare Campus. And then finally, we'll have Dr. Stephen Lin, who is the Clinical Associate Professor, Vice Chief of Technology Innovation, and Medical Director at Stanford Family Medicine. Let's start off with Dr. Trounce. Please feel free to share your screen.
Great. So thank you so much for having me speak today. It's a pleasure to join. So as Dr. Shen mentioned, I direct the biosecurity program here at Stanford. And for the last 10 years, I have been teaching a class on this, believe it or not, on biosecurity and pandemic resilience, and thought of integrative ways of responding to these kinds of threats. And the class is very interdisciplinary. It involves not only medical aspects, but also policy and technology development aspects. The reason I mentioned that, I know the Rambam, you guys are very innovative as well as far as technology development. So I thought this may be relevant, this approach. And I know we only have a few minutes, but I want to base my remarks actually on the paper that I wrote for the Hoover Institute at Stanford, which I used, and actually some of the slides for today's remarks are also based on the slides I used to brief Condoleezza Rice and George Schultz on the topic of pandemic resilience. And again, very integrative policy type look. And with this pandemic, in some ways, everything has changed and our world has changed. And in some ways, nothing has changed. Because the truth is, the way this played out in our society was very predictable. And we wrote that out actually in those essays in Hoover. And this is a citation to those essays here. You can just Google them under my name on Hoover and pandemics. So basically, the main thing I want you to take away from these few minutes together is that I really hope that we don't let this pandemic go to waste. And what I mean by that is that this is not the last pandemic we will have. And this is not the last biological threat we will have. And in the big scheme of things, quite frankly, it could have been a lot worse. It could have been something more like Spanish flu, which actually had 10% mortality and affected about a third of the world's population. So we will have future events. And I really hope that we use the momentum generated by this pandemic to prepare for the future. And let me tell you very quickly as to why this threat is actually increasing from these kinds of biological threats, and also how we might be able to address it and to approach it conceptually. So pandemic threat is increasing due to a number of factors. We're obviously very aware of the natural threats right now, but the truth is there's also threats which are man-made. With advances in synthetic biology, we've essentially democratized our ability to alter infectious organisms to make them more infectious and more deadly. And this completely changes the landscape of the threat. And this is something we should keep in mind in our future preparedness efforts. The natural threats, the risk from natural threats is also increasing. Basically, infectious organisms now travel with the speed of an airplane. And these things take off like wildfire. Urbanization is also a really big driver. Climate change, as mosquitoes and other animals move further north, they carry the infectious organisms with them. And very importantly, there are more of us on the planet, and we're increasingly coming into contact with animals, which increases the chance of infectious organisms jumping from animal population into humans. And that's how most pandemics and just infectious disease outbreaks get started. Most of them are zoonotic in nature. And let me just illustrate that to you by very quickly about Ebola. everybody seems to have forgotten Ebola by now. Everybody's so focused on the current pandemic. But basically, since 1976, there have been numerous Ebola outbreaks, all of which have been tiny, less than a few hundred people, and isolated to remote villages in Africa. In 2014, 2015, all of a sudden we had 30,000 infected, over 10,000 dead, and the whole world scared. Same exact virus, completely different pattern of spread because the world is getting more global. People travel. And I should also mention that since the 1980s, we've seen a 30-fold increase in infectious disease outbreaks caused by these zoonotic agents. So it's the number of outbreaks and also the scale of them and the size of them. So let me talk very quickly about our general approach to pandemics. So the usually very politically popular thing to do is, at the start, and this is exactly what happened with Ebola, exactly what happened with COVID-19. After the emergence of an infectious organism, there is this massive resources poured by governments and other organizations towards development of vaccines and specific pharmacological measures, specific pharmacological countermeasures. The problem with this approach, reactive approach, I should say, is that it oftentimes fails because simply due to the timelines. By the time we have vaccine, the pandemic is over or is close to being over. This is what happened with Ebola. By the time we had a vaccine for Ebola, the outbreak was over. It was used for subsequent outbreaks, so it's still helpful, but not for the current one. With this one, I know with Pfizer's news, we're all very optimistic. But I would not be completely surprised if this pandemic is over by the time, before the time we are able to actually immunize everybody. But nevertheless, so the reason I mention that is that this is not a go-to strategy for pandemic response. We've already been in this for a year. And I'll just skip over in the interest of time. Our surge capacity is limited, as we all very well know. So basically, this is also not a go-to strategy for pandemic as a way to make ourselves resilient to pandemics. We can only do so much. So if we don't have specific countermeasures, we don't have necessarily the surge capacity, we go to the tried and true measures like quarantine, isolation, and other infection control measures. They worked in the Middle Ages. They actually worked in the Spanish flu pandemic. Cities which implemented these aggressive lockdown type measures earlier were able to dramatically reduce their mortality, in some ways by as much as 80%, and that data is on the CDC sites. But these measures are very expensive, not only economically, but also socially, politically, spiritually. So we have to have better tools. And this is really my point, my whole point. Essentially, control of all pandemics and of all infectious disease organisms boils down to one step only, and that's interruption of transmission. As much as I love medical treatment, I'm an ER doc and all that, but really, this is really the lever that we can affect for maximum effectiveness. You can do it in two ways. You can do it through altering environment by engineering controls, or you can alter it, or you can affect this change by altering how people behave. And this is what policy is all about. This is what lockdowns are all about. This is what remote working is all about and such. So the same exact thing can be thought of through this framework. It's through the hierarchy of occupational controls. And that's actually the hierarchy utilized by OSHA. And at the top of the hierarchy, as far as, this is a hierarchy used for protecting workers from any kind of threats. In this case, being COVID-19. So most effective is elimination of the hazard. And this happens through lockdowns or through working remotely. The next one down, but still pretty high on the hierarchy, is adjusting the workplace. And this is really what engineering controls are all about. And this, I feel, is the area that's really underinvested right now in a global scheme of things. And below that is adjusting work processes. And that's where implementing hygiene practices, staggered shifts, decreasing building occupancy is all about. And the very bottom is PPE, because that puts the entire onus on the provider. And I know I'm very cognizant of time. Let me just tell you, focus my last slides on engineering controls. And you can do this in a number of ways. You can optimize ventilation, filtration, and airflow. We know there's so much data now pointing to the fact that COVID-19 is transmitted by super spreader events, and those in turn are mediated largely by spread through air, whether droplet or airborne. So if we can figure out ways and devise new engineering controls of interrupting that kind of spread, that will be massively helpful in controlling this, as well as beautifully future pandemics, because so many organisms are spread this way, including the flu and so many others. Optimizing temperature and humidity controls. We can utilize the fact that the viruses die at higher temperatures and higher humidities. Antimicrobial surfaces. For example, we know that COVID-19, SARS-CoV-2 rather, doesn't live on copper for longer than 4 hours. Compare that to a week on plastics and smooth metals. And of course, UV light. UV light, by the way, upper room germicidal irradiation has been used even in the 30s and 40s, very effectively, I might add, to interrupt the spread of tuberculosis and measles. So I can talk a lot more on that, but I will very respectfully stop to allow other speakers to talk. And please feel free to reach out to me if you have ideas. I'm always very open to collaboration and advancing possible solutions to this and future pandemics. Thank you very much. Okay, I'll stop sharing now.
Thank you, Dr. Trounce. It's very fascinating to kind of hear that very global and broad perspective on pandemics. Next, we have Ms. Hyams. Please go ahead and share your screen.
Good morning and good evening, ladies and gentlemen. I'm really honored, excited, and proud to present here. But before I start, I would like to thank the organizing committee members, and especially to Yaeli Marom that helped me so much in organizing the Israeli part of the conference, along with Dr. Halbertal and Dr. Hani Bachus. My presentation will deal with a new normal life with COVID-19. But first is the question, whether we are going to have a new normal or our life will return to be the same normal life as we had before. From my point of view, we will have a new normal that will combine COVID-19 patients with our regular patients, and we will have to learn how to live with it and how to manage health system between the waves. Will we have emergency and routine, or how will we be the new normal? Meaning, we will learn to contain the surge capacity of COVID patients. So in our new normal, in our current situation, pretty soon here in Israel, we are expecting to have the winter flu combining with the combination of COVID-19. As we say here, flu and corona, flurona. How will it look like? Will the masks do their job? How many patients will we have? And many more questions. So if you look at a hospital like Rambam, from my perspective, it will ideally have the new normal additional COVID-19 wards, such as intensive care, internal wards, and an emergency department. We will need to learn to act like accordion. We will need to learn how to deal with the ebbs and flows of the surge capacity. We need to learn to be able to increase the system ability to be flexible. Every healthcare system will have its own flexibility and capabilities. Dr. Halbertal showed you yesterday in his presentation the underground hospital that really gives us a very good solution for our reference scenario for 900 patients. Let's elaborate for a few seconds on our emergency department with COVID-19 patients. Here, we are going to have a challenge because we will have to see how we can manage the emergency department with 4 kinds of patients in separate areas. We need to have the regular emergency department, another area for all the respiratory patients that are suspected for COVID-19. We need isolation rooms for patients that come after home isolation period with different health conditions. And of course, we will have to have designated the ED for the positive COVID-19 patients, and it is located in our underground hospital. Looking at the intensive care department, we always think about the increasing of the resources of the equipment in the space, but in order to be able and truly to be ready for the surge capacity, we need to look not only at the ventilators and all the other machines, we need to seek and look at the team preparedness. Actually, this is the main issue. During the waves of COVID-19, we were able to train and educate inside the hospital a lot of physicians and nurses, and this is just an example of the numbers of the nurses that were trained in a different scenario that are connected to the COVID-19. Thinking about the community, we as a hospital need to understand that we have to shift missions and help creating the abilities for the community home hospitalization for COVID-19 patients and for other internal patients. By strengthening the abilities to take care of the patients there, we will reduce the load of patients that will, and we will create a defense shield for the hospitals. When we look at the geriatric hospitalization, during the COVID-19 period, we saw a lot of geriatric patients that were admitted to the hospital because the need of their needs of suitable treatment that was lacking in the geriatric facilities. If we would be able to help to improve their abilities and help to strengthen their treatment capabilities in the institute, they will allow those patients to stay there in the place they live and will get the service from the staff and teams they know in the regular facility and not be hospitalized. Special consideration needs to be taken into elective activity, operations, and procedures. During the first wave, we've seen a lot of patients that were left at home with severe medical problems and ended with deterioration in their health condition. During the second wave, we've decided to renew the elective procedures. Actually, it was the hospital director decision how many patients the hospital can absorb for operations and procedures. This situation is like communicating vessels or equilibrium. If you put a lot of resources for having their operations and procedures done, you might have less resources to treat the COVID-19 patients. Each hospital needs to have a combined ability to operate all the patients and don't stop the elective activity. Looking at the patients with chronic illnesses like COVID-19 patients with kidney disease that need dialysis, they will need it to be done in designated area with manpower and equipment. Oncology patients, unfortunately, due to these circumstances, some of them didn't start their maintenance treatments and medical procedures in the first wave because we were very afraid that they will be infected by the COVID-19. Now we understand that we need to screen hematologic patients for COVID-19 before hospitalization. We hospitalize the patients and let them be isolated with their own family member for the treatment. Towards the end of my presentation, we are standing in front of an unknown enemy, and we see that it is as an unknown threat. That means that we need to be humble. We need to understand that we don't know everything about it. We need to be prepared as always and to be ready. We need to plan, we need to train, and our mission is to save life. Thank you very much.
Thank you, Gila. Let's move now to Dr. Lin. Feel free to share your slides.
Well, thanks everyone. My name's Steve Lin, and I'm here to present the primary care perspective on this panel. So at Stanford, as in many parts of the country and pretty much part of the world, primary care's response to COVID has really been a two-pronged strategy of both testing and telemedicine. Today, I'm mostly going to be focusing on telemedicine as our principal tool against COVID, and then highlighting three particular challenges that I think we will be facing as we move into the new normal. But first, a little background. When COVID-19 erupted in the US back in March, patient visits plummeted in the US and have only started to recently recover, largely due to the widespread adoption of telemedicine. At Stanford, we were able to avert a potential crisis in patient visit volume drop by converting from nearly 100% video visits to 100% in-person visits to nearly 100% video visits within the span of a week and a half. Prior to the pandemic, the percentage of telemedicine visits to total visits was only about 1% nationally and also at Stanford. And this increased exponentially in the second quarter of the year, up to 35% nationally and 75% in Stanford, and has somewhat tapered off a bit, but remains well above pre-pandemic levels. And a lot of experts believe that telemedicine is here to stay and will be an important part of our care delivery model moving forward. But it's not a perfect tool. So what are some of the challenges that we need to be aware of as we move into the new normal? The first challenge, I think, is that the use of telemedicine and the recovery health systems have been unequal. The adoption of telemedicine has been fairly robust in the West, but not so much in parts of the Northeast, the Midwest, and the South, where COVID-19 death rates are actually the highest. Furthermore, larger clinics are using more telemedicine, while smaller ones are really struggling. And perhaps it's not surprising that smaller clinics are not recovering as well as larger ones, and many have or will be closing their doors to patients. Visits for young kids have also not recovered relative to adults, and many are missing their primary immunizations, things like measles, mumps, rubella, varicella, hepatitis. And it's not just age, but also race. So who can forget that Black and Latino patients are contracting and dying of COVID at much higher rates than their white counterparts. So the basic question of how do you deliver care equitably using telemedicine in the US remains a pressing challenge. Challenge 2, cancer screenings have not recovered, and the delays in diagnosis will cause preventable deaths. Take a look at this data pulled from 60 healthcare organizations covering about 10 million patients. It shows that between the months of March to June alone, hundreds of thousands of breast, colon, and cervical cancer screening exams have been missed. And although cancer screenings have recovered somewhat, there's still about a 1/3 down from pre-pandemic baseline. Now, this is a big problem because we are anticipating potentially tens of thousands of excess cancer deaths due to missed screening. This national population-based modeling study from the UK shows that due to delays in diagnosis alone, increases in breast, colorectal, lung, and esophageal cancer deaths are to be expected, and may be as much as 60,000 total years of life lost from the pandemic alone. So the basic question of how do we get patients back to cancer screening? How do we think about maybe perhaps newer and innovative methods of screening patients at home rather than forcing them to come into our health systems? That's still something we need to work out. And then challenge 3, if virtual visits are here to stay, then we need better tools to care for patients in the post-COVID world. At Stanford, we are actively researching artificial intelligence-based strategies for risk stratification and remote patient monitoring for our entire population of primary care patients. Such tools are needed if we're really to switch the paradigm of care from thinking about care as these episodic visits centered around the clinic to what it really should be, which is continuous longitudinal care of patients wherever they might be. Understanding patient risk better also allows us to use telemedicine better by combining their global risk scores with chief complaints to have a better understanding of the safety and appropriateness of telemedicine for particular patients. These types of tools, as well as others, are the types of solutions that we need if we are to retool primary care for the post-COVID world. And if anybody is interested in learning more, I urge you to take a look at this manuscript that my team published recently in Mayo Clinic Proceedings. And I think my time is up, so happy to take questions in a panel or answer questions offline by email.
Thank you, Dr. Lin, and thank you to all the panelists. We do have a few minutes for a couple questions. I think just to piggyback off what you were talking about, Dr. Lin, where do you see the role of remote monitoring in the domain of telemedicine? We see a lot of interest in being able to monitor patients at home.
I think it's a huge area of opportunity, Sam. One of the issues with virtual visits is that we're unable to gather some of the data, the objective data that we as physicians need in order to accurately evaluate and provide treatment recommendations for patients. Remote monitoring fills that gap. It allows us to know what's going on with the patient, from things like basic vital signs to even more innovative things like continuous glucose monitoring for diabetics using CGM monitors, for example. And so, and there's a lot of focus on using machine learning tools and AI to evaluate and interpret all of that massive amounts of data coming in so that it's interpretable and actionable for physicians. So I'm really excited about work in that area.
Great, thank you. Gila, I had a question. There's been a lot of concern in preparation in terms of having intensive care capacity and capability. As we move back to a more normalized state in the future, what's your perspective in terms of how to improve our ICU capability, especially for future pandemics?
So I think when we address the nurses situation, which I feel I can speak better about it, it's really something that here in Israel is taking into concern. This year, 850 nurses started to learn 1 year of course of intensive care. This is a large number, and it was supported nationally. Here at Rambam, we sent 100 nurses to get a course, and then they'll be able to help. Another issue is to find pivot nurses that can run the intensive care together with the help of nurses that we will bring from internal departments. And also it's very important to use this time for nurses to get prepared. So they will do their clinical instructions, and they will go inside the department and will try to do their best to be ready. And something else that is important is to think about the ECMO and the ability of nurses to treat ECMO patients, because usually it's not enough to buy the equipment, you need to have the manpower to operate it, and this is a big problem.
Excellent point, that it's more than just the physical space, you also need people and the caretakers. Milana, one final question. What do you think are the most compelling opportunities when you think about building resilience for future pandemics?
Yeah, no, thank you, Sam. That question, right, cuts to the things I believe most about. And I really think a lot of this boils down to engineering controls, because I see the future. I know we're all of us are so focused on dealing with the current pandemic. But again, I think much more effectively, so we don't have to have a year of agony when we don't have vaccines, we don't have drugs, we worry. I just think it would be so much more productive if we have built-in engineering controls that we can just kind of switch on with a button when we get that first page, something scary. And when we can do this again, it doesn't, and by the way, those controls are applied to healthcare systems, but they should really apply to schools, offices, places of worship, everything. And I think there's so much we can do. I feel like we don't need to, we're using very old tools right now. We're using several hundred-year-old tools. And I think, again, things like I mentioned, antimicrobial surfaces, enhanced ventilation, filtration, air purification, use UV lights. Those are the things that I feel like we should really take an opportunity and invest in them now.
Thank you. And thank you to all the speakers, and really appreciate you joining us.